move on to last but not the least and the most important topic, that is the surgical approach in patients with acute retinitis and necrosed retina by Dr. Munna BHENDE. And I am sure that Dr. Munna BHENDE needs no introduction. She is a teacher to many of us who are sitting here in this session and to most of the vitreoretinal surgeons practicing all over India. So I thank Dr. Munna BHENDE to accept this invitation to be a part of this course. And please, over to you, ma'am.
Thank you, Sangeet, for inviting me, and good morning, everyone. I'll just start with a small disclaimer. We have an excellent uveitis department in our hospital, so I will rely a lot on them for the medical management. And we've seen some wonderful videos. My talk will probably be on tips of how to manage these complex cases. I see Padma in the audience. I'm sure she'll help us with the medical part of it.
The next session starts at 10:30.
So my talk is on surgery for retinal detachment due to viral retinitis. I'll start with the case of a middle-aged diabetic gentleman who presented with a dense vitritis, dense panuveitis in the right eye, poor vision, and he had a peripheral necrotizing retinitis. The AC tap showed a positive PCR for VZV, and he was managed accordingly. He had an initial improvement of inflammation, but like we all know, as the necrotic patches heal, they develop retinal breaks, and he developed a retinal detachment a month later. He also had steroid-induced worsening of diabetes and did not undergo surgery immediately because he went all around the country for a second opinion. So then he finally arrived with no view of the retina due to a dense vitritis. He also had some cataract, which is why you see that the view is hazy, sufficient enough for us to operate. Look at the vitreous in this case. You see it is thick. It's opaque in places. Here I've managed to induce the posterior vitreous detachment. Now you see, as I'm trimming the vitreous in the periphery, you start seeing the necrotic patches. Here you see the peripheral areas of necrosis, the multiple retinal breaks. Here we are trimming the vitreous. Now the breaks are coming into view. And removing a few of the membranes. Acute retinal necrosis is the viral retinitis that is associated with severe reaction and PVR, in contrast to CMV retinitis. And finally, because there were 360-degree multiple breaks, I did a 360-degree cautery, PFCL, 360-degree RR. I cut off all the peripheral necrotic retina and then flatten the retina, 360-degree laser and silicone oil tamponade. And this was 2 days post-operatively. You see the eye is quiet. We did a PCR of the vitreous, which was positive for VZV. The patient was advised to continue the antivirals for 2 months along with tapering of oral steroids, and this was 8 weeks post-operatively. He had a dense nuclear sclerosis. Best corrected vision was 636 n18. He has recently undergone cataract surgery after being lost to follow-up for almost a year. And again, as is required, the antivirals have to be continued. And a close watch to be kept on the fellow eye, because especially acute retinal necrosis, you may start seeing necrotic patches in the fellow eye in the periphery if you miss out on your examinations. So retinal detachments in eyes with viral retinitis are broadly in 2 major categories based on the immune status of the person. In immunocompromised people, typically AIDS-related, we have CMV retinitis, and in immunocompetent patients, acute retinal necrosis due to the HSV, VZV, and Epstein-Barr virus. What is the pathogenesis? Inflammation leads to retinal necrosis, multiple retinal breaks, and retinal detachment. And the difference in clinical response is a clue to the immune status of the patient. We have certain common challenges. They are associated with infection, so manage the infection, manage the retinal detachment. How do you handle both concurrently? Can you prevent retinal detachment? And of course, a close look at the systemic status of the individual. Like our patient had diabetes, then you have patients who have HIV. So, yeah. So, as I mentioned, acute retinal necrosis is commonly caused by HSV, VZV, or Epstein-Barr virus, typically in immunocompetent young adults, presenting initially as a few foci of retinal necrosis in the periphery with occlusive arterial vasculopathy. But you see a rapid disease progression in the absence of therapy, typically circumferential, and you see these retinal breaks that appear in the periphery, and it's characterized by a prominent vitreous or anterior chamber inflammatory reaction. The retinal detachment usually develops as a late complication between 1 to 2 months, and you see this moth-eaten appearance of the retina here. You see these sharp-edged borders, and as I mentioned, the fellow eye can be involved in 1/3 of the cases, usually between 1 to 6 weeks of presentation of the first eye. First, you have to confirm your diagnosis, put the patient on antivirals and systemic steroids. You may choose to use intravitreal antivirals before you do surgery, of course, and this is sometimes based on the paying capacity of the patient, and of course you combine with systemic steroids. Now, vitrectomy could be diagnostic, optical, where you clear the dense vitreous opacities, which may facilitate treatment of retinal breaks to prevent retinal detachment. This is a rare situation, but occasionally we have done it. Most commonly, surgery is to manage the retinal detachment or vitreous hemorrhage. You can do laser if the view is clear enough for retinal breaks. However, its role in prevention of retinal detachment is very questionable. And you may choose to do a scleral buckle in these eyes because their extensive degree of fibrosis, you may not be able to access the periphery, and occasionally you have peripheral retinal breaks. Prophylaxis of RD is a little difficult because the media is typically hazy. One may choose to do a vitrectomy with acyclovir lavage and then do endolaser to the breaks and endotamponade. However, we noticed that there may be progressive involvement of retina beyond the area of laser barrage, which is why sometimes it doesn't work. And the breaks in acute retinal necrosis are multiple, large, and posterior, as you see here. Very often we may see patients with what looks like a chronic retinal detachment. The eye otherwise looks quiet, but if you see this peripheral moth-eaten appearance, it could be a possibility that patient had ARN in the past. And as I mentioned, significant traction, epiretinal scarring, and vitreous base fibrosis. Basically, the patient is immunocompetent, so the ability to mount an immune response is very high, which is why you need to add on the steroids as well. The surgical challenges: you have a thin necrotic retina, you have an inflamed vitreous, and if you look here, this is an old video, but I've used it because you see the breaks very nicely. An exaggerated postoperative inflammatory response is quite common in these patients, and you need to have long-term systemic medication and prolonged silicone oil tamponade, because sometimes if you remove the oil too early, the recurrences are very severe and then the eye cannot be salvaged. In contrast, CMV retinitis is common in immunosuppressed individuals. There is none or minimal vitreous inflammation. These patients very rarely present with PVR unless it is part of immune recovery vitritis when the patient is on heart therapy. Rarely one may get this dramatic appearance of frosted branch angiitis. These patients have a poor response to acyclovir. And CMV retinitis has hemorrhagic retinitis, which has a perivascular distribution. Again, the retinal detachment develops due to breaks that occur in areas of heel retinitis, and the lack of contrast may make it difficult to identify the breaks preoperatively. Severe PVR or vitritis is unusual in these cases. Occasionally, exudative retinal detachment may occur. Again, the management is a combination of medical and surgical therapy. Keep a watch, make sure the patient is on heart therapy, is under care of an internist for this. These are the surgical techniques that are possible. And here you see this video. You see the eye is relatively quiet, the vitreous is clear, you have these multiple retinal breaks. Again here, a very clear vitreous, and you see the areas of heel retinitis in the periphery that occur, and very often you see some scleren coming out, which gives you a clue that there is a retinal break. The challenges are again the presence of active CMV retinitis along with the detachment, increasing incidence of PVR in the heart era, you need to decide on silicone oil tamponade duration due to increasing longevity of these patients. When I started doing VR surgery for these eyes, we didn't expect patients to live longer. We were not removing the oil, but now I find I'm removing silicone oil for most of my cases. And I think most importantly, we need to keep a watch on the systemic medications. Thank you.
We have 2 minutes more for the session to end. So any queries? Yeah.
And acute retinal necrosis, if you operate early, they generally tend to do well. I had patients who have 6/6
40 micrograms per
vision, but I think you have to keep a watch on the disc because optic neuropathy can also occur, and I think that is something which is why we need to continue the patients for long-term medication. Padma, maybe you would like to add something?
I had one question. So
Yeah.
you said we can use acyclovir lavage when we're doing vitrectomy for CMV retinitis?
No, for ARN, previously that was one of the recommendations, that when you're doing a therapeutic vitrectomy for just clearing the vitreous so that you can treat the breaks. But that's no longer recommended. We use it very, very rarely. And there are studies which has proven that it doesn't really work as well. Systemic medication is good enough. Because we are likely to use a tamponade after that.
Yeah,
so
exactly. You're going to wash it off.
Yes,
at the
this
end
is
of the
only
course.
when you're doing it in the acute phase when you want to treat the breaks, not if you're doing it for the RD. No.
Coming to the medical management, in addition to the antiviral and systemic steroids, aspirin can be used in ARN cases. That's controversial, but that can indirectly help to prevent the pallor development. Ischemic component it can take care.
Thank you.
Thank you. So we have run. Yeah.
Is Foscarnet available, madam, in India?
Sorry?
Foscarnet you can easily access Foscarnet injection.
No, not easily. We are
So
using
I
only
tried
cancer
that actually. I could not get it. It's very costly also.
Yeah, no.
Almost
I think
25,000.
probably Alai had presented some papers much earlier, but whether they were done here or somewhere else.
We have to
I'm
get
not sure.
from abroad and it's cost
Yeah,
around
no, we are
25 to
not
50,000.
using Foscarnet.
thanks.
These are just options that are mentioned.
And actually the RDs after ARN surgery, they have very high incidence of PVR and recurrences are common. The literature says that actually more than 50% end up with vision of 20/200 or less. So what's your take on that?
Yeah, that's why probably most of these ARN cases we end up cutting the periphery because that removes the fibrotic element. So I found that works fairly well, and keep the oil for as long as you can. I use 5,000 centistokes so that the chance of emulsification is less and we may not remove it. I found the risk of recurrence is more after silicone oil removal, sometimes after cataract surgery also.